Hey, hi, Manish. How are you? Great to hear your voice. Hi, Bill. Everybody on the panel. Gives us great pleasure to present from Chandler. I'd like to thank all the course directors for giving us this chance. It's been many, many years I've been doing this, and it's been fun all along. Just a quick intro. Behind me is my absolutely stellar team: Christina, Belia, Chris, Leslie. To my right is Leah, who's going to help and scrub with me, and to her right is John. We have a great case. Can you go to the PowerPoint slides, please? So this guy is a 68-year-old gentleman. He presented to me with stable angina. It was class 4, improved to class 2 on guideline-directed medical therapy. This had known CAD. It had previous intervention at John C. Lincoln Deer Valley about a year ago. He's got a BMI of 43.5, which makes it a little challenging. He had a MPI done in northern Arizona, which is where he lives at, and he had a moderate-sized ischemia in the intralateral walls. His EF was normal. Next. Here are some angiograms from what we did about a month ago. So as you can see, we'll play that and then loop it. Just hit play. Yeah, it should play. Yeah, so he's got a distal left main lesion and a CTO of the right. You can see that the right, I don't know if it projects as well, but the PL fills via left atrial branch coming off the circ. The PDA fills from septals. And as you can see, he has a high-grade distal left main. Next slide. So about a month ago, we did a DK crush of the distal left main, and the result was acceptable. I didn't necessarily balloon and the septal at that time, but there is a stent across the mid-LAD. There is a good septal that is usable as an interventional collateral. And next. And my plan today was to treat this right. It's a large vessel. It has diffuse disease, both proximally, the intact bifurcation. It's a multi-option case. There are good retrograde options. Questions that will probably come up are how we handle the proximal segment that's diffusely diseased. May need to roto it to be able to get what we need to get down. And then is there a second CTO in the PDA is another question. So with that, I'll show you our current setup shots, and then I'll let you all help me plan the case. Let me go back so you guys, okay. So this is our setup shots for the day. The left main bifurcation looks great. You can see that there's a bunch of disease in the proximal segment, heavily calcified right. The CTO itself is in the descending segment. It's probably a short segment. And there are good interventional collaterals, like I said earlier. Move to the next slide, next image here. Is the image projection pretty good? Are you guys able to see what reasonably well?
We're seeing your dual injections and at this point.
Yeah. Okay. And so this is the dual injection, and then this is the areocranial, a setup shot to looking at the epicardials. I mean, the septal collaterals and the left atrial collaterals from the left atrial branch to the PLB.
Yep.
And I'll stop here before I don't show anything else, but just ask the group how they would approach this, and then I'll tell you what we've done so far.
All right, Robert. So what would you do? What would your options be here to treat it, and which would you pick first?
Sure. Did we see like an AP or an LA crane or anything like that to reconstruct the distal RCA?
So I can show you that.
The only reason I ask is what I think we're seeing is a really short segment CTO.
This is the cranial shot, Robert.
Okay. What we may be seeing, there's a little bit of streaming down there in the mid-vessel, but I think there's a short segment CTO down there with a potential distal landing zone, I think. And if that's the case, we've got good retrograde. Well, we've got a potential interventional collateral from the LAD. The circ stuff I'd need to investigate a little bit more. It does appear that there's an epicardial off of there, but what I think I would probably start off with, because I have an unambiguous proximal cap, again, I think with a little bit more injection on the right guide to make sure, probably start with AWE with an ADR bailout with a septal as a third and potentially an epicardial as a fourth. Although you could argue whether that epicardial as a fourth should be a fourth versus a star strategy.
All right, just because we had a patient on the table, let's let you get to work here, Ashish. So where are you and what are you doing?
Yeah, so what I did was obviously, so our setup is bifemoral because I think he had a little discomfort going radially a month ago and preferred for us to go femoral. So we went femoral. We have a 7, both groins, and I have a JR4, I have a liquid guide extension, 7 French, which will allow me to treat the proximal right, which I intend to with atherectomy up front, so I'll be able to get all my gear down without struggling. And as far as the next thing that I did was I was able to go retro wire the septal, and I have right now I have a microcatheter in the PDA, as you can see, and I have a rotowire down knuckled, or actually this is the rotowire, then antegrade microcatheter that's in the distal right, but proximal to this proximal cap. And I plan on atherectomizing the proximal vessel first, get my liquid and my balloon into the mid right so that delivery of everything is going to be simple. Park my equipment in the distal descending RCA antegrade, and then either work antegrade with a wire escalation strategy, or if possible, just run a retrograde wire and see if it lands with the retrograde wire strategy into either the guide extension or a ringer or whatever else we choose to have in the mid right.
All right. So the next move here is you're going to just rotoblate your proximal right?
I think I'm going to roto. I did not have to cut the wire because I think we have enough of room in the proximal right itself. So, and I have a liquid 7 French, so I can roto through the liquid, which is a good advantage of having the liquid. Right. And here I go. So Rob, got the wire.
I'm going to go back to.
At least we know where your proximal cap is now.
Yeah. How many people have experience with liquid? And there's a lot of different guide extensions on the market now. How do you make that decision, Mike?
Let the wire go. Tension. Yeah.
Joe.
Oh, sure. We've been using liquid for a while, and the really nice thing about liquid is the ID is really, really nice. Now, one of the things, I keep saying when I was your fellow, but it keeps getting further away, and once you get almost close to 10 years, it gets, so you keep saying it. One of the challenges is anytime you get something, anytime you get an improvement in the device, there's usually a cost, right? So you don't get anything for free. So that increased ID, it is stiffer, right? And so you have to just be more careful about delivering it. It's also not something that you're probably going to get down in this particular distal right? If you had to do reverse cart really far down past the mid-vessel, this is probably not the vessel for a liquid that far down. It's going to be great if you just need to get into the proximal vessel with support and everything else, but as with everything, there's pros and cons there.
So Mike,
that was a quick run. How about, I think there was a little...
Actually, let me go to Rebecca. So obviously, we've got a high-risk case going on at Honor. This was a distal left main with an RCA CTO, which would make it high risk. So do you want to talk about sort of one got done with Impella, one got done without? What's the decision process? What are your thoughts about sort of quote unquote protected PCI with hemodynamic support?
The case was divided out nicely here where the left main was taken on at a separate setting. The indications for Impella placement with normal EF are very scarce. And so, in my practice, sometimes that becomes frustrating because implementing an Impella up front with a normal EF like this patient, and you use that and something goes wrong in terms of complication of access or something like that, how do you justify that and how do you defend yourself? So I think it's a standby situation unless you can really support it with hemodynamics or some kind of thing up front, or when you start your ballooning of your left main or your intervention, your hemodynamics change and then that justifies adding it at that time. The other case is a graduate level case in hemodynamics. With multi-vessel disease, multi-vessel disease. The AV fistula presents a major challenge to that. So, I think at the very least, hemodynamic support up front in that case, and we'll get back to it, I'm sure. But those are sort of my general thoughts.
Just to add to those excellent comments, I think these are two very different cases when you're talking about hemodynamic support, and you're right. There aren't really great indications to guide us for protected PCI on when we should be using upfront Impella versus just doing the case without. And hemodynamics can guide it, but as you mentioned in this kind of graduate level course of the aortic stenosis and multivessel CAD, what we do have is registry level data for protected PCI, and that suggests that if you use a bailout strategy, outcomes are much, much worse than if you use upfront MCS for a complex case like that with aortic stenosis, left main, and RCA. So I would argue that in a case like that, obviously upfront MCS is a very good decision, but the extra layer in that case is you've got severe peripheral vascular disease and you're trying to minimize complications, because you're right, if you use the MCS and there's an issue related to it, you need to be able to justify it. And one aspect to that case that we didn't get a chance to talk about is if this is someone who's thinking about getting a valve, you have a lot of additional imaging to help guide how you're going to use that MCS. So you've got TAVR CTs that are going to give you all of the vascular access options. And if you see femorals like that, that could be a case where you know the chance of hemodynamic instability is great and a bailout strategy is going to be very dangerous. You might consider an upfront alternative access MCS in a case like that as well.
I think that's a great point.
Oh, go ahead.
And
But the
I
point
think that's
that
a
I just wanna-
fantastic point, because you don't want to be struggling to get the sheath in and across a stenotic aortic valve during CPR. And Rebecca, I think that is, I mean, there's a lot of considerations here, but I think that is primary or proximate in the decision algorithm to put the Impella up front.
Ashish, you're going to pre-dil your right and bring your guide extension further in. Is that your plan before you decide whether you're going to do antegrade or retrograde as your next move?
Exactly. So I've just have a 3040 balloon in the proximal right, and I'm going to inchworm the liquid down, and I'm just going to inchworm the liquid. It's a little bit stiffer than other guides, but once you're in, it's like a rock. It doesn't move at all. That was pretty good right there.
So in this situation where you've got a retrograde mic catheter in, you've got an antegrade wire in, what's going to drive your decision to keep working antegrade versus keep working retrograde at this point?
Efficiency, as I learned from you. Go up, please. Like whatever I think is, I mean, I'm not going to get like locked into one mode and just get dogmatic. I'm just going to see where the wire goes retrograde, and if it goes, I'll take it. If it doesn't, then I'll try antegrade. I don't think that at this point, having a multi-option case gives you all the luxury of getting efficient, especially in a guy who's a big guy and racking up radiation here as I work. So
okay.
And that bend that you're working on with the liquid is one of the areas where it's going to struggle, because there's a big piece of calcium, it's rigid, and the angle. So that's just, one of the things. Plus, look where the mouth is compared to the rest of the wire. It's going to be potentially a bit unfavorable.
Yeah, the nice thing about that, Robert brought this up, and I'm conflicted, but the 7 French liquid has the same idea as an 8 French everybody else, which has a lot of advantage. The other is it's got a shorter back end, so you can trap. So the problem with trap liner is it's great antegrade, but it's really not great to deliver stents and do PCI through. Liquid, despite some of it, you can use it for both, which can be a nice situation. Farouk, when you're looking at a case like this, what's driving in your head? Should I always just do antegrade wire first, or, I've got a good collateral, should I just go up front retrograde? How do you balance those risks and approaches in your head?
Ashish. Good job, buddy.
Look at that.
Yeah, always really has to be thought about, and I think we look at, a lot of it has to go related to the retrograde tolerance. This is great, of course, to have a retrograde option right away. This really improves the solvability of the case, but in this case, it was also done after fixing the left main. There's no left coronary ischemia that's likely to happen here, so this is going to be well tolerated. But that's a big consideration, is what's going to happen when that wire and microcatheter cross the septal, and how's the patient going to tolerate it. So that's a big discussion. If it crosses, very smoothly, like Ashish has made it look effortless here, then you're in a great spot to solve this case very definitively. I think one of the nice things about this case setting up is that it was really thought about, like, what's going to be my problem? Even if I cross this lesion, I have a ton of inflow disease that's calcified. Sometimes it's easy to get locked in about just crossing the lesion, putting the wire down, getting the microcatheter, and then you realize you have 60 millimeters of calcified lesion upstream, especially if you get subintimal and have to cross with an ADR, and then you have a bunch of upstream calcium. You're always struggling about rota up front, worrying about getting into the ADR planes. This was really super well thought of and just simplifies the actual crossing.
So way to do retrograde wiring, true to true, that's great. So as everybody just saw, you just took a retrograde wire, went up, it crossed the lesion beautifully. That prep antegrade helped make it easier. So in a situation like this, Ashish, there's a lot of discussion, like, should you now flip to an antegrade system and get rid of the retrograde gear, or do you prefer to do your intervention on an externalized wire? And if so, why would that be important for people to know?
I think so, right? I mean, an externalized wire gives you the best rail, and I think in this case, like Farouk was saying, if there are circumstances where continuing to remain retrograde with gear in the heart can be potentially hazardous, this doesn't seem to be one of those situations. But in general, the support that you can get with an externalized wire is better than anything else that you'll ever get. So yes, I'm going to stay on the externalized wire here, but in some instances, I have had to bail and switch to an antegrade option for purposes of patient safety.
Can you tell us what externalization wire you're going to use and why you chose that wire by chance?
It's R350, and I think that's my go-to wire. I haven't really had any.
Obviously there's RG3 and R350. Does that change your thought process depending on which wire you're using to externalize to stay on it?
I think R350 gives you more support. Our RG3, of course, it's stainless steel and it's got less support. So, yes.
In a case like this with the JR guide, it is really nice to have the externalized wire. Just, it's going to make it a lot easier to deliver those stents distally. And also, if you need to get near stenting the ostium, it's a much simpler situation to just back out your JR guide now. One would have often started with an Amplatz guide here, but in this situation where it was really solved so quickly, retrograde, this is a great position to be in.
Just because we're not at the other room and now we're just into balloon and stenting, I do want to make a comment. In our lab, the TAVR would have been done already. That's the patient's going to die from their AS. They're not going to die from the coronary disease. And there's really zero evidence that fixing coronaries prior has any real value. And if you fix the valve, she's not sick right now. And you can manage her coronaries much easier. So I think, again, that's a shift. There is a lot of people doing high-risk coronary intervention simply to take the risk off your TVT registry data. And I don't think that's the right reason to be doing it. Same thing, there's a lot of BAV done that is simply used to get people's risk done. So I would just say in our lab, we would fix the valve because that's what you're likely to die when we work on the coronaries, and it's likely what's going to give you the most hemodynamic short and long-term benefit. Then we would take care of the coronaries.
Yeah, that's been the shift in our lab as well throughout NYP. Is the TAVRs first, and it's taken time to evolve, but that's what we've been doing. Here, these are all, Ashish has made this look easy, but things that for us mere mortals, you want to make sure that you got a retrograde gear. You want to make sure the ACT is checked very routinely. Make sure the patient's doing well. Make sure you've got your retrograde and collaterals protected while you're working. All this stuff is the reason why you do this with a partner or with good scrub techs, so that while you're working, other things are being looked at and reviewed. And this is where teamwork is critical in labs that don't have that, especially where I am, where we're growing. You've got to build that before you start these types of cases.
You saw how I backed the left guide out and got
What?
my retro gear, and now I'm just going to balloon and then IVUS
So are
and
you?
optimize. If Alok has stuff going on that you want to go see, I'll be happy to defer to him so that you guys get a chance to see what's going on at Shea as well. And then I can come back whenever you guys need to, and I'll be happy to show you what I'm doing.
And like anything, right? This ended up looking very easy. That's great. It's wonderful when it goes smooth. Often it won't. I think the important thing for everybody in the room is if you want to learn to do this, you can. But you have to put in the same level of commitment and work and coaching and risk and building skill sets to get there. And I think that's an important thing. You can look at what Ashish is doing. Well, he's been doing this for 17 years. And so he's built a lot of that skill set up. I remember him when he started. He wasn't this good. So everybody, well, neither was I, so you were around when I started. But I think it's important for everybody to be very humble because it's not what you can do, it's what the patient needs. And if you can't do, how are you going to get the patient what they need done? Either you've got to learn it, like you were talking about building your program, or you've got to be willing to go somewhere else to get the patient taken care of. So are they ready for us to go back? Because we're trying to figure out what's going on over at Honor Health Ashish, so we're just going to watch a balloon. He's obviously going to IVUS this. You know.
And you know, one thing, Bill, that you and I talked about last night, and I think that's really important, is the culture, right? The institution where you work at, and the team in the lab that allows you to do these kind of things and take on innovative stuff. Like if you want to go, for example, learn Slash or learn some things that we learned at a meeting. And like you said, you know, get people to your lab, collaborate. And, you know, I think that you can't work in silos, and you got to get people to work together and understand what's going on in their hospitals and their labs. That's the fastest and the easiest way to continue to grow. And I know it's difficult because our workflows are challenging. Everybody's running around, has busy days, and it just gets worse. But you have to take time because this is part of you growing professionally. Otherwise, you're going to get stuck.
Right. So Nadia, sort of following up on that, you went from Michigan to Vanderbilt. I think I've got that correct. Different cultures, different academic institutions, different partners. How do you manage a culture in some ways, and can you change a culture? Can you help it grow and change?
Ivis?
Well, that's a really great question. I do think that the leadership of an institution, division leadership, cath lab leadership plays a very big role in setting the culture. So if you're a leader, you cannot really underestimate the importance of how you act as a role model for all of your colleagues, how you interact with people, how you interact with your patients, your colleagues, how you discuss complications, all those types of things. So, I mean, I've, had a really great learning experiences in different locations, different aspects of clinical care. And I mean, I would say that, I'm very grateful for all the experiences I've had. I feel like it's helped me grow, both in terms of toughness as well as compassion. And I think that couldn't be understated.
All right, so this is going to be an interesting IVUS. Where's Akiko? Where's Akiko when we need her?
Right.
I mean,
You know what? I'll tell you, Bill. So I was doing a live case in July for CTO Plus for India, or actually no, TCT India, in July last year. And she was India, and she basically completely destroyed my. Because I don't have the HD IVUS here in my hospital in Chandler.
I wasn't going to bring it up, but I wanted to throw you a bone. I was going to leave it alone.
She refused to interpret the images. She said that ultimately Ajay had to step in and show some kindness to me because they said, it's terrible. How can I even see what's going on?
I'm going to also throw you the bone, which is what he's using is better than not using IVUS. And in the end of the day, all you need to know on IVUS is how big should I make the stent, and do I need to do anything more about calcium? All the rest of the discussion is a discussion. And what you find, when we institutionally went to image-guided PCI, our stent size and NC balloon size increased 0.5 millimeters. And if you think about that from a cross-sectional area, I used to be able to do math. It's a big difference in your MSA, which is a big difference in restenosis. And there's a great John Wooden quote, right? Because we deal with a lot of restenosis, and it's 90% an underdeployed stent, which is if you don't have the time to do it right, when will you have the time to do it over? And this gets back, giving somebody restenosis is a horrible complication. And, it doesn't feel like a complication because it happens a year later. But it is a complication of interventional cardiology, and it's preventable to a large degree. All right, Ashish, so you're unfortunate IVUS wouldn't go all the way.
Yeah,
we
so
did
I'm
see
actually
some
going to
things.
but I'm just going to continue to work on getting.
And still a lot of extra calcium, or
Yeah.
sort of
go up.
And while it wasn't high def IVUS,
eccentric calcium.
I was.
My
How long do I sit here and let you word search? Yeah, there was interestingly a lot of eccentric calcium there, and oftentimes we don't have to worry about it. But I will say there were some areas there where the eccentricity really had some luminal encroachment that makes you pretty worried about stent expansion, particularly in that. Again, it wasn't a linear pullback, so some of that, but it looked like in that prox vessel where where your liquid wouldn't go. It looked like there was a big old knob of eccentric calcium pushing in there, so it gives me some concern that NC balloons may not be the ultimate solution there.
I mean, I know where you're going with this. Like, rotoshock sounds like a really good option, but let's first image before we arrive at that conclusion. Yeah.
Yeah, I mean, there's a lot of different ways to fry this fish, right?
Yeah.
Because how good is Shockwave going to work with that much eccentric calcium? You could talk about OPN. You could talk about scoring balloons.
Yeah.
I mean, you can get an hour and a half discussion about how to manage calcium. At the end of the day, do your best.
I'll take the.
and I think because you have the imaging, this is key. You realize that you would never know that ahead of time just by the NC balloon profile, and so the eccentricity is super important here. You could upsize your rotobird, you could do IVL, you could do scoring. Lots of things are on the docket here, but you had to have that image, and even if it's low quality in terms of transducer resolution, this is bulky enough where it's obvious, and you made a big impact.
So, Rebecca, your thoughts about using Shockwave without imaging? Does that make sense?
Yeah, no, it doesn't make sense. And I think it's so interesting because we see all of this data. The data is really becoming very sophisticated, showing outcomes are so much better with imaging. But the US still lags behind in imaging-guided PCI. And it's not like your stent all of a sudden gets magically better because you put an IVUS down or an OCT down. Your interventions are only going to be as good as your ability to interpret that data. And so, we're looking at a really complicated CTO case and talking about really nuanced imaging interpretations. But for everybody in the room, I think we really need to consider ourselves all now imaging experts, or we should aspire to be imaging experts and not just coronary interventionalists that put balloons and stents in. Sure.
You saw what I just did? So the IVUS wasn't going, and it goes back to what I was talking about, using the externalized wire as a rail. What I had Leah do was aggressively pull on the other end of the wire and basically was able to make that bend with the IVUS. And now I'm at the crux with this IVUS catheter, and it'll allow me to do a legitimate assessment of the entire vessel. Sorry, guys, didn't mean to interrupt, but Rebecca can go back to what you were saying.
So do you want to interpret the IVUS for us, or should we have somebody on the panel do it? And
I can. It would be great if somebody on the panel did it.
All right, Nadia, you're up.
Okay. Well, you can see a shadow of calcium over there, sort of around 3 o'clock. That's kind of demonstrating some eccentric calcium. There was a couple of spots that looked like you might have some nodular calcium because it was really sort of protruding into the lumen of the vessel, and that was even after your, rota run, but more than likely because it's sort of eccentric, maybe it's shaved off a bit. But you do have a good amount of the circumference that isn't calcified, so I guess that's hopeful for eventual stent expansion. Like right there, we have a nodule.
Yeah, the area that you had to grab both ends of the externalized wire and shove the IVUS past, probably that.
How do you manage distal vessel sizing in a CTO because of negative remodeling? do you, Ashish is busy looking and thinking, so Robert, you want to take that one?
Actually, what I would do is I usually start with 80% of the distal reference vessel and use that as the stent size to start with, and then use a platform that will allow me to expand. It also depends if I'm intraplaque or extraplaque. I'm obviously less aggressive if I'm extraplaque. In this case, we know we're all true to true or intraplaque. So I think the distal reference was, I would say, closer to 3 millimeters, and I would probably start with another NC inflation, try to get all of this calcium dealt with in a maybe better way. I don't see good enough fractures all along the course, and then come back with IVUS to determine how well it's fractured, and then start with like a 3048 and then and go back from there. So that would be my plan here.
So Ashish said something that I think is very important to everyone in the audience, and I want to talk about this. So Manish, he talked about making sure I use a stent platform that can grow. So how important is to have that stupid chart that says a 2.5 stent only goes to 3.75 or 3.5 when you're going to drop and deploy a stent?
NC balloon.
Yeah, I mean, that chart has become important, and we're looking at it, you know. I mean, I'm asking that question a couple of times a week because I can't keep it straight. We only have a couple of stents on the shelf now, but without imaging, you're not going to know. And you know, again, we've talked about it. I talked about it in my clinical trials. You know, imaging is essential for these cases, whatever you've got, and you've got to put the right size product in that's going to grow to the right size so that you actually get drug delivery and actually a result that's going to be durable. So you're not going to put a 2.5 stent distally and make it grow to 4.5 in most stent platforms. And so, you know, all this becomes very important. It seems simple, but you just got to keep it straight.
And this becomes the restenosis issue. If you put a 2.5 stent in a 5.0 right or a 3.0 stent in a 5.0 right, when they come back with restenosis, you can't really fix the problem, which goes back to if you're going to do it, do it right at the most opportune time, which is the original procedure. And it means that you may have to learn how to under-deploy stents, where you're going to put 3.0 and 3.5s in stents that aren't 3.0 and 3.5. So when the vessel grows later or things go on, or a left main into another vessel with their size, you have to be able to manage that. Again, these are things you need to develop a skill set, and you also need to be willing to say, I don't, like Manish said, I don't know what stent platform will go to what size, so I have to look at it all the time with the fellows and figure it out. Because the worst thing you can do
for 1 second?
Is put a stent in that's too small.
Bill, do you see the image here?
Yes, sir.
Do you feel like, so in this view, this is a 2.5 30 NC.
Okay.
To me, it looks pretty well expanded in this view, but I think the importance of an orthogonal view can't be overemphasized, especially if there is some region of question. I don't see any region of question here, but we're going to go RAO here and just make sure that the vessel is adequately prepped so that in both views we have good stent expansion. It looks pretty good here. And this was where I had to use the externalized wire to suck the IVUS catheter in.
It's a great point. You know, it may look expanded in one view and not in another. And again, you know, you don't want to be fooled. These are underfilled vessels. He got down there. You saw a lot of eccentric calcium. You put a lot of effort to roto the prox. You want to get this perfectly expanded throughout. This is going to be about 90 millimeters of stent. You cannot afford to not be appropriately prepped and expanded.
Mike, we don't have great therapy for eccentric calcium, and you can be limited sometimes on the compliance of the architecture of the vessel. What advice do you give people to sort of how far is too far when we're dealing with eccentric calcium?
Oh, well, you know, as my main mentor, Dr. Kern, says, you know, the way to limit your mistakes is to stop one step before you make it. But I think the issue here is, you know, you don't have anything. If you look at Bob Riley's calcium algorithm here, we don't have greater than 270 degree arc of calcium in any one spot, but we have a lot of difficulty passing gear, whether it's the IVUS catheter or an underinflated balloon. And so, you know, you're at this crux of, you know, what do you do? So I think at this point, you're either trying to IVUS right now to see whether you got fractures, and that will go, and the IVUS catheter will pass better. You go to a next higher size and shorter non-compliant balloon to see whether you can expand that better. You utilize a specialty balloon like a sculpting balloon or a cutting balloon, or you just jump to shockwave depending on your situation in your lab and how much you're going to be judged. But I'm not sure I would go to rotablator or do that again. But I think that's sort of the decision-making point right now of what do we do right now, because we got to maximize this and we got to keep it open.
I mean, we do have data showing that concentric versus eccentric, there is no differential in stent expansion when we use IVL, so we do have to probably consider that. But I want to talk about, so I've been doing with these cases, and I'm not trying to say it's right or not, but slightly controversial point. I have been with these cases based on the IVUS that I saw, stenting inflow and DC being the outflow. You had a 2 and change, maybe 2.5, I couldn't tell from the IVUS, not calcified distal outflow. To your point, Manish, like you're dropping what, 90 millimeters of metal in this, or am I dropping some stent up top and DCB in the outflow? Because the thing is, once I've stented the CTO and the inflow, if I'm wrong, I can stent the outflow if I made it. But I don't know, man. If it's me and it's close to my BIF and I'm worried about, or bifurcation, I heard BIF this weekend was not the word of choice. That's fine. The bifurcation this weekend, I don't know. I think that DCB might be the way to go. But again, I know that's not data-driven or anything else.
Most of what we do isn't data-driven. So, Ashish, they're ready for us back at Honor Health, and I know you're going to get this done. So we'll come back to you once you get it stented. Really interesting case. Thank you for allowing us a lot of opportunity to have some interesting discussion. We look forward to seeing the final result here. Okay.
Well done, Ashish. Great.
Thanks a lot. Thanks again. Great. Thanks. Appreciate it.